Good evening, everyone. Thank you, GK sir and Sikla for this opportunity. As I said, today we'll have to discuss about continuous renal replacement therapy. And in this short section, I will be speaking briefly on principles, modalities, indications, and timing of CRRT, and a short note on RRT prescription, and the role of CRRT in certain special situations, and the usual access for CRRT anticoagulation used, and finally I will conclude. So acute kidney injury is common in the ICUs, around 25% of all ICUs, and it affects around 40 to 60% of patients in medical ICUs, and around 10 to 25% of those who are having a KI will require renal replacement therapy, and among them around 50, there is a mortality of around 50 to 60%. So in acute kidney injury, the major concern is fluid and metabolic abnormalities. And RRT can be considered as a bridging therapy that allows patient to survive while the native kidneys recover. A short review on AKI definition by Kedika 2012. Stage 1 is the rising creatinine by 1.5 to 1.9 times baseline, or by more than 0.3 milligram per DL, or a urine output of less than 0.5 milliliter per kg per hour over 6 to 12 hours. Stage 2 is rise of creatinine by 2.9 times, and polyuria for more than 12 hours. Stage 3 is 3 times rise in baseline, or absolute value of more than 4, or initiation of RRT, or anuric for 12 hours, or less than 0.3 ml per kg per hour urine for more than 24 hours. So RRT can be considered from Kerigo stage 2. So the principles of all extracorporeal renal replacement therapies involves diffusion, convection, ultrafiltration, adsorption, or a combination of these. So in dialysis, there is diffusion of solutes from blood to the dialysis compartment. Dialysate will be flowing in a countercurrent fashion. And in convection, there is a pressure applied to the blood compartment, and the solvent and the solute goes across the membrane, and along with the solvent, the solute is dragged, leading to convective clearance. So in convective clearance, larger molecules can be cleared, and usually for convection, a high flux filter is required. Dialysis can be done with the mid or high flux filters. Now, in all these membranes, there is some adsorption happening, and there are certain filters made exclusively for adsorption also. And the ultrafiltration depends on the extra pressure that is applied to the blood compartment, leading to removal of fluid. Now, the solutes that are removed during a dialysis therapy can be divided as small molecules, medical molecules, and large middle molecules, and essential proteins. So in all dialytic therapies, the usual small molecules, urea, phosphate, creatinine are removed, and in convective therapies, the middle molecules are also removed, which commonly like beta-2 microglobulin, inflammatory markers, and myoglobulin. So the first successful human dialysis was done in 1945 by William Kolff using the drum dialyzer. And in 1977, Peter Kramer performed the first continuous arteriovenous hemofiltration in Germany. So there are various factors to be considered before starting CRRT, like the timing when to start a CRRT. Especially, it is debatable if there is no urgent indications or absolute indications for initiation of RRT. And once it is decided what modality to choose, with what intensity, what membrane to be used, and the anticoagulation and access. So modalities of renal replacement therapy can be intermittent, continuous, or hybrid. So in this talk, the continuous therapies are continuous vena-venous hemofiltration, continuous vena-venous hemodialysis, hemodiafiltration, and slow continuous ultrafiltration. So in this talk, I'll be focusing mainly on CVV HDF. In CVV HD, here, I said the blood and the dialysate will be flowing in a counter-current fashion, and there is exchange of solutes, and with the pressure, ultrafiltration also happens. In CVV HF, there is no dialysate flow, but a replacement fluid is given. So this can be given either as pre-filter or post-filter, and whatever fluid is given is removed in the filter as and thus removed as an ultrafiltrate. And for getting the same efficacy as dialysis, we need to give much higher amounts of replacement fluid in hemofiltration. Hemodifiltration employs both dialysis and ultrafiltration, hemofiltration and hemodialysis. And so there is both diffusive and convective clearance. And according to the extra fluid removed, ultrafiltration, net ultrafiltration also achieved. Now, as sir was saying, a comparison of intermittent hemodialysis and continuous renal replacement therapies. To summarize, there has been no difference has been demonstrated by any RCTs. The initial study suggested that there are certain advantages for CRRT because there was a increased possibility of renal recovery of CRRT and mortality was less. In a study conducted by in a Cochrane review by Remindran et al. In 2007, there was no difference with respect to mortality, renal recovery, and risk of hemodynamic instability or hypertension episodes. In a study by Mahato et al. In 2001, published in Kenya International, which included 166 patients, increased mortality was observed in the CRRT group, but which can be explained by more severe illness in the CRRT group despite randomization. And among the patients who survived, they are more likely to show renal recovery. In a recent secondary analysis of AKIK and ideal ICU trials by Gaudry et al., published in Critical Care, they said that CRRT as first modality did not improve any benefit, not provide any benefit in terms of survival within 60 days or kidney recovery, and might be associated with less favorable outcome in patients with lesser severity of disease. So finally, the selection of modality depends on the capability or availability of the technology and its inherited risk and the current needs of the patient. CRRT is generally preferred when the patient is hemodynamically unstable and when there is raised intracranial pressure like patients with stroke, intracranial injury or liver diseases. In and the intermittent hemodialysis or prolonged intermittent renal replacement therapy or SLED is preferred if the patient is hemodynamically stable and rehabilitation or mobilization is a need or a priority. Intermittent hemodialysis has certain advantages like it involves only short sessions, so allow mobilization of the patient, especially if the patient has to be shifted for any physiotherapy or imaging, and the cost is lower. And disadvantage is the fluid removal and hence the solute removal is rapid, which can lead to hemodynamic imbalance in these patients. CRRT advantages are there is hemodynamic stability, there is no treatment-induced increased intracranial pressure, and there is fine fluid control. So it allows the intensivist for better fluid control over 24 hours and allows him to give more fluids or more drugs as required. Now, and also in certain studies have shown that there are increased cytokine removal in convective therapies, so which may help in stabilizing sepsis patients. Disadvantages are it is prolonged, there is risk of hypothermia, then the patient needs immobilization, the costs are higher, and the patient might need prolonged anticoagulation and thereby increased bleeding. And because of antibiotic removal continuously, the therapeutic levels may not be achieved with CRRT. So in CVV HD or hemodialysis or mid or high flux dialysis is used, and in hemofiltration and HDF, high flux is required. Hemodialysis, dialysate flow is there, hemofiltration replacement fluid is required, and in HDF, both dialysate and replacement fluids are there. Hemodialysis works through diffusive clearance, hemofiltration by convective clearance, and HDF by both. The blood flow is around 50 to 200 ml per minute in all modalities. Ultrafiltration is 1 to 8 ml per minute in hemodialysis and 10 to 60 ml per minute in both hemofiltration and the hemodiafiltration. In hemodialysis, the dialysate flow is 15 to 60 ml per minute. In hemofiltration, the replacement fluid rate is around 10 to 60 ml per minute. And in HDF, the dialysate flow is 15 to 60 and replacement is around 10 to 30. And in the middle molecule clearance is achieved by converted clearance. So we can achieve it by in CVS or CVV HDF. Now comparing hemodialysis and hemofiltration, there is no specific CRRT modality which has been shown to provide better outcomes. And in a meta-analysis by Frederick et al. Published in 2012, compared hemodialysis and hemofiltration in AKI. There was no difference in mortality or dependence in survivors, vasopressor use, or organ dysfunction. But hemofiltration was associated with increased clearance of medium to large molecules, including inflammatory cytokines, but at the cost of an earlier filter failure. Now, in most cases, the choice of CRRT modality depends on the equipment and staff availability and expertise of the clinician. The usual absolute indications are for initiating a patient on dialysis is fluid overload secondary to resistant diuretic therapy, refractory metabolic acidosis or pH of 7 less than 7.15, which is refractory to medical management, hyperkalemia, refractory to medical management, or uremic symptoms or signs. RRT is considered in other situations like poisoning, hyperthermia, life-threatening electrolyte derangements like hyponatremia in the setting of AK, and progressive azotemia or oliguria unresponsive to medical management, and certain metabolic disorders leading to hyperammonemia, and in some cases of acute liver failure. Now, the timing of RRT, as said, is debatable, and in the absence of absolute indications, it can be challenging, and there can be conflicts also. And observational studies had favored early initiation in the earlier studies, but later RCTs found no difference between early and standard timing. So the major trials which looked into the timing of RRT were Akiki study, Align study, Ideal ICU study, and Start AK study. The only study which favored early initiation was the Align study, which was continued in Germany, and it was predominantly in surgical patients. In all these studies, the early initiation was within 6 to 12 hours of stage 2 or stage 3 AKI. And in the delayed arm, most of them involved absolute indications which were discussed before. And in 2 studies, AKIK and Align, blood urea was also used as a criteria. Now, in all these studies, one thing to be noted was in the delayed arm. The delayed arm, there are some patients which recovered spontaneously without dialysis. The AKIK study, 49%, and the Start AK study, which included around 2,900 people, around 38% did not require dialysis. So early dialysis initiation can lead to dialysis in certain patients who might not have required dialysis. Now, the mortality was not different in AKIK Ideal and Start AK trial, but the mortality was lower in the Align trial, 38.4% versus 50.4%. And there was no difference in ICU stay, and there was no difference in days free of mechanical ventilator in all studies except Align. And so this says that, so as per the largest study, it says that there is no particular advantage in starting dialysis early, and if started early, the patient may be subjected to extra complications of vascular access, episodes of hypotension, and delay in renal recovery. And with regards to timing of RRT, the AKIK2 study, it looked at whether delaying patients more than the usual absolute indications, like critical stage 3 oliguria more than 72 hours and the blood urea more than 112, which is controversial. And but they compared it with a more delayed strategy where the patient was started only when the patient developed any emergency, like pH less than 1.5, hyperkalemia more than 6.5, or severe fluid overload and pulmonary edema. So in this situation, they concluded that the additional delay in RRT did not confer any additional benefit and was associated with the potential harm because there was increased mortality in that group. So, summarizing, the initiation of dialysis in a patient with AK has to be individualized. I need to look at the severity of the illness and the trajectory of the disease, the necessity of RRT, the risk of RRT, and certain other factors. So, we have to look at the severity of AK, the severity of electrolyte and acid-base disorder, look at fluid balance, the need for to give more fluids, the need uh, to keep the patient in negative balance. And when the fluid overload start to impact other organs like lungs, like pulmonary edema or worsening pneumonia, heart failure, etc. And you need to look at the necessity of RRT, where we need to see, we need to assess whether, like for example, some transient episode of hypertension, the patient may be olivary for some time, and there will be transient worsening of his blood gas or RFT. But if the reason for hypertension can be corrected, the patient may escape dialysis. And we need to look at the underlying comorbidities also. In a very elderly patient with low lung compliance and patient heart failure, he may have to initiate early. And we need to look at other acute organ dysfunction also, like the presence of other acute hepatitis and pancreatitis. They may need dialysis at an earlier time, and we may not wait for the standard indications to appear. Now, the risk of RRT has also should also be assessed, like whether the patient can be mobilized continuously, whether there are issues in getting a vascular access, whether the patient is hemodynamically stable, and the risk of infection, and certain other nutritional problems also has to be addressed. And all the wishes of the family has to be attended to, and the goals of care has to be consistent with the care and the availability of machines and nursing staff, and cost also has to be addressed before deciding to initiate a patient on dialysis. So the Furosemide stress test will can predict whether a patient will progress to need for RRT, where a bolus furosemide dose of 1 to 1.5 mg per kg can be given, and if the output is less than 200 ml over 2 hours, it implies that the patient can go into further worsening of renal function and need for RRT. The biomarker TIMP and IGF, combination of both, high positive value has been associated with the need of RRT. Now, once the patient has been decided to initiate, we need to give a prescription. And the usual modalities of CRRT, which we popularly use, is CVV hemodialysis and CVV hemodiafiltration. And in both, we need to give the blood flow, the dialysate flow, the net fluid removal, the anticoagulation to be employed, and CVHDF, we need to give the replacement fluid dose also. Now, the dose of the CVHD or HDF can be assessed by various methods. It can be assessed by the net effluent dose, which is a surrogate marker for the solute removal, or it can be assessed by the urea removal, like the urea reduction ratio, or the standardized KT by Vs and equivalent KT by Vs. For practical purposes, we focus on the prescribed dose or the effluent dose, which is the net effluent, which is the sum of the substitution fluid, dialysate fluid, and the net fluid removal. And before going to prescription, a recap of the CV-HDF circuit, where the blood is taken from the patient, the anticoagulation is employed, and the substitution fluid, a part of which is given before the filter and a part of which is given post-filter. And there is also a dialysate flow in the countercurrent fashion in the filter. And if the anticoagulation employed is citrate, then we need to correct it by calcium infusion from a line outside of the circuit. The RRT prescription dose is told in terms of the effluent dose, which is the 25 to 30 ml per kg per hour. And this has to be prescribed so that a 20 to 25 ml per kg per hour can be achieved, because obviously there will be certain time lost in like shifting the patient. Sometimes because of alarms, the machine will stop. There will be some time in change in the bags, etc. Now, the effluent is the sum of replacement fluid, the dialysate fluid, and the net fluid removal. The replacement of the dialysate is usually in the ratio of 1:1, but in heavier patients or in patients sepsis and rhabdomyolysis, the proportion of replacement fluid can be kept at kept higher. And pre-filter and post-filter replacement, it is also usually kept equal, but usually the pre-filter replacement is kept higher so that there is better filter life. But usually the solute clearance is better if the replacement fluid is given post-filter. Now, usually in the AK setting, the more importance is given for the fluid and electrolyte balance. So usually we give the replacement in the pre-filter side. Now, doses higher than this 25 to 30 ml per kg per hour can lead to protein malnutrition, deficiency of vitamins and micronutrients, and inadequate antimicrobial drug levels. So, for example, if there's a patient with 85 kilograms, we prescribe a blood flow of around 175. Blood flow is usually kept around 100 to 200. Higher blood flows will lead to more need of citrate if citrate is used, and lower blood flows will lead to reduced efficiency and higher risk of filter clotting. Now, the replacement is dialysate is almost equal. So, for a patient of 85 kg, net removal of around 2,800 is required. And now the replacement can be given as 1,400 ml per hour. The dialysis flow can be set at 1,400 ml per hour. And in the replacement fluid, around 50% can be given as the pre-replacement and pre-filter replacement, and 50% can be given as a post-filter. Leading to a dose of around 2,850 ml per hour. This comes to around 33 ml per kg per hour. In CVST, we need to give only the dialysate flow, which is usually around 20 to 50 ml per minute, and higher doses as tolerated and as per the clearance is required. And the blood flow is usually 2.5 times the dialysate flow. The blood flow systole is around 100 to 250. The lower blood flows can increase hemofilter and cycle failure due to stasis of blood and increase in filtration fraction. And between 100 to 200, there is no much difference in solute clearance. And if the blood flow is increased more than 200 to 250, there is more need of citrate, and which can lead to citrate-related complications. Now, is there any water studies with regard to need for a higher dose of CRRT? Various studies like ATN study 2008 and Renal study in 2009. They all showed that there is no benefit with a higher dose of CRRT. And in sepsis patients, the reverse study of 2013, they studied 35 ml per kg per hour versus 70 ml per kg per hour, and there was no significant difference in MAP or inotrope requirement. And a particular note of filtration fraction has to be made, because when we increase the removal or increase the filtration, the post filter replacement, there is increase of filtration fraction where the blood gets concentrated inside the filter and will lead to clotting of the filter. So the filtration fraction, which is a ratio of ultrafiltration flow rate to the plasma flow rate, and it has to be kept less than 20 to 25%. And the filtration fraction can be lowered by keeping the UF flow or increasing the blood flow rate, or using more percentage of pre-filter replacement. The UF removal is according to the fluid balance required, negative balance required according to the hemodynamics. It is can vary from around 50 to 150 ml per hour. Now the solutions used in the CVSDF. When for usual CVSDF, when the heparin or used or no anticoagulation is used, Prismasol solution is used as the replacement and dialysis fluids, and it is similar to the plasma, contains calcium, magnesium, and some amount of lactate. Now, when in the Prismaflex system, for the pre-replacement fluid, pre-filter replacement fluid also contains citrate, which is a regiosit, and which contains around 18 millimole per liter of citrate. And when this is used, it is advised to use a calcium-free dialysate, which is bifossil. This does not contain calcium as a dialysate. And the post filter also we can use either bifossil or prismasol according to the potassium requirements. It is noted that bifossil contains potassium, and so if the patient is hyperkalemic, this has to be avoided. Now, access the preferred access is temporary dual lumen central venous catheter. The first choice is right jugular vein, and then femoral veins and left HAV. The subclavian has to be avoided, and if the catheter has a third limb for administration, it should not be used for administrating drugs or parenteral nutrition or measurement of central venous pressure. Now, anticoagulation can be systemic, regional, or anticoagulation free. For systemic anticoagulation, we can use either heparin. In regional, we use citrate or heparin and protamine. So, in renal citrate anticoagulation, the citrate is added to the access line. The calcium citrate complexes are formed. The free calcium in the circuit is decreased, preventing circuit clotting. A significant amount of calcium citrate complexes are lost in the effluent. The dialysate solution has to be calcium free. The post filter solution may be calcium containing, and the return calcium return complexes are converted by liver to carbonate and calcium, and the lost calcium is replenished via the separate IV line. So in CVSDF, we regiosit bifossil and parenteral calcium gluconate has to be given. The target circuit calcium is 0.25 to 0.35 millimole per liter. So at the ionized calcium levels of 0.25 to 0.35, the clotting is reduced, and if it is less than 0.2, there will be no clotting. And the target serum calcium is 0.9 to 1.2. The regiosit flow is calculated by the machine, and bifossil flow is calculated by reducing regiosit flow from the effluent flow. In CVVHD, separate ACD infusion with parenteral calcium gluconate infusion can be used. Now, when citrate is used, sometimes there can be a citrate excess or citrate toxicity. In citrate excess, there can be metabolic alkalosis, but the total calcium by ionic calcium will be less than 2.5. In citrate toxicity, there will be high anion gap metabolic acidosis, and the total calcium by ionic calcium ratio will be more than 2.5. Now, in CRRTs, regional citrate is preferred over heparin. It has been shown to have a reduced risk of bleeding, reduced blood transfusions, and increased hemofilter life. And but there are certain disadvantages like need close monitoring of electrolytes, ionized calcium and pH, and alkalosis. And in certain situations like profound shock and liver failure, it can worsen the lactate levels. When heparin is used, usually a loading dose of 1,500 to 3,000 units is given with a maintenance dose of around 5 to 10 units per kg. And the APTT is monitored every 8 hourly with a target of 1.5 to 2 times the normal APTT. If low molecular weight is heparin is used, loading dose of 0.5 mg per kg is given, maintenance of 0.05 mg per kg per hour. But this has a prolonged action, and especially in renal failure. And if at all there is bleeding, it cannot be fully countered by protamine. And if there is severe coagulopathy or bleeding, heparin dialysis can be given, but it associated with a poor filter life. Now, extracorporeal therapy in sepsis. Various therapies are tried like high volume ultra hemofiltration, high adsorption hemofiltration, high cutoff membranes, and hybrid systems. But there is no convincing evidence of mortality benefit with these therapies. Hemofilters are there which can absorb the inflammatory mediate mediators onto their surface, but the RCTs and current sepsis protocols do not support their use. But in clinical practice, obvious benefit has been observed in a carefully selected patient. So, cytosorb is one such hemofilter used. It consists of porous polymers organ beads, helps in the removal of cytokines, bilirubin, and myoglobin. And oxaris has a three-layer membrane. It has a AN69 membrane, and it absorbs both the cytokines and endotoxins. Now, in ARDS, the patient will be in positive fluid balance, and CRRT may be considered to reduce extravascular lung volume and more readily support a conservative fluid management strategy. Now, therapies are available to remove carbon dioxide along with CRRT. And in certain metabolic disorders which leads to hyperammonemia, CRRT may be considered. And in liver failure, usually in acute liver failure, which is associated with cerebral edema and hyperammonemia, CRRT can be helpful. Now, CRRT, it is usually a hypercatabolic state, and there are loss of nutrients. So, like glucose, amino acids, proteins, trace elements, and water-soluble vitamins. So, there is special attention should be given for additional nutritional support. Energy requirement is 25 to 35 kilocal per kg. 60 to 70% should be carbohydrates. And there is additional protein loss in CVVH in filtration. So they require around 1.5 to 1.8 gram per kg per day. And vitamins and minerals has to be supplemented. And the drug dosing also has to be modified according to the modality. With higher UF rays and with convective clearance, more drug is required. And almost all drugs are dialyzable except dialyzable or filtered except ceftriaxone, azithromycin, clindamycin, linezolid, doxycycline, metronidazole, tigecycline, polymyxin B, voriconazole, amphotericin B, and echinocandins. Now, when to stop RRT? Usually, the RRT is stepped down, like it is left to sled and then further step down to intermittent hemodialysis. So finally, the kidney function should have recovered and should meet the patient needs of fluid and electrolyte balance. Spontaneous urine output is the best predictor, and it can also be stopped when it is no longer consistent with goals of care. The 24-hour creatinine clearance has also been used to predict stoppage of renal RRT. If 24-hour urine clearance is more than 15 to 20, then it is possible to keep the patient off RRT. Now, as with any therapy, this is also associated with many complications like catheter-related complications, electrolyte imbalances, and the circuit-related complications. Also, hypotension, hypothermia, and special attention has to be given to hypophosphatemia and hypomagnesemia, and that has to be corrected parenterally or orally as required. Concluding, AKI in ICU carries a high risk of mortality. RRT in AKI is a bridge therapy while the native kidneys can recover. And the timing of RRT initiation has to be individualized. Accelerated strategies are associated with added resources, higher infections, and RRT dependence without substantial benefits. Now, the modality, diffusion or convection, both have similar outcomes, and any of them can be used in a hemodynamically stable patients. But in hemodynamically unstable patients or patients with raised intravenous pressure, CRRT with converted clearance is preferred. Now, the target dose of SDF is around 20 to 25 ml per kg per hour, and there is no demonstrated additional benefit of higher doses. Citrate anticoagulation is preferred for filters are available, but it requires frequent monitoring of various blood parameters. Now, extracorporeal absorption therapies for sepsis may be helpful in selected situations, and special attention has to be given to nutrition and drug dosing. Thank you.